All right, well, we'll get going. Good evening. I'd like to welcome everyone and thank you for joining. I'm Marika Russell. I'm an endocrine head and neck surgeon at Harvard Mass Pioneer. And on behalf of the American Head and Neck Society, we're very excited to bring you this 1 hour of programming. This session, as you can see, is focused on the endocrinologist perspective on the management of thyroid cancer. And the idea behind this is that we as surgeons routinely collaborate with endocrinologists, but naturally we see things through the lens of a surgeon. And so the idea here is that we really want to focus on what it is like to think like an endocrinologist. What are the challenges? What are the issues? What are some of the fine points that as surgeons we may overlook that our endocrinology colleagues really want us to understand? I think as surgeons, we can sometimes dominate the conversation. And so the idea here is that we really want to put the spotlight on the endocrinologist perspective as we go through some of these clinical cases. And in doing this, we also want to convey some of the practical things that endocrinologists discuss with their patients. We really want to get a sense of what is it that they say to their patients when they're talking about RAI or TSH suppression, so that when we get these questions from our patients as surgeons, we can give them informed answers and we can really strengthen the collaborative nature of our care. So I'm going to introduce the panel in just a moment, but I want to acknowledge the work of the Head and Neck Society in supporting this programming, and particularly I want to thank Betty Mulugeta for her support. I imagine that many of you on the call are already members of the American Head and Neck Society. There are a number of benefits to being a member, as you see here, and if you are not already a member, we would encourage you to do so. So I'll go ahead and introduce our panel. We have a really esteemed panel here tonight. I want to thank all of our panel members for being here, for taking the time to join us and lending their expertise. I will be co-moderating this session with Dr. Mike Tuttle, famed endocrinologist and chief of the endocrinology service at Memorial Sloan Kettering Cancer Center. We have Dr. Lindsay Bischoff, who is professor of medicine and medical director of the Vanderbilt Thyroid Center. She's also director of the Endocrinology, Diabetes, and Metabolism Fellowship Program at Vanderbilt. We have Dr. Laura Bucay, also an endocrinologist. She's associate member at Memorial Sloan Kettering Cancer Center and an associate professor of clinical medicine at Weill Cornell Medical College. She's very active in the thyroid cancer research space. We have Dr. Naifa Busaidi, who's a tenured professor at MD Anderson. She has significant experience and has published extensively in the advanced thyroid cancer space. And last but not least, we have Dr. Julia Noel, who is our lone surgeon on the panel. And she's a very accomplished head and neck endocrine surgeon at Stanford University, clinician and researcher. And we will look to her today to sprinkle in a little surgical counterpoint into the conversation. So I'll go ahead and start with the cases. We do have a chat function, so we encourage you to place questions into the Q&A, and my co-moderator will try to gather those questions as we go through cases, and I will do the same for him. So the first case is that of a 29-year-old woman. She was seeking reproductive endocrinology care for fertility-related issues, and the provider palpated a thyroid nodule. So she underwent a workup which demonstrated elevated TPO antibodies. Her TSH was in the normal range, but at the upper limit, and her free T4 was also low, and she did have positive thyroglobulin antibodies. She's an otherwise healthy woman. She does have a very strong family history of hypothyroidism, Hashimoto's disease, and she works as a nurse. So she's very clinically savvy. And so this was her ultrasound image here for the nodule that was palpated. And I won't belabor the imaging too much, as we'll just go on to say that this was a almost 2-centimeter nodule on the right that was graded at TI-RADS 5. You can see here that the axial images on the right and the sagittal images on the, axial images on the left and the sagittal images on the right. She did have an additional small nodule that was seen in the contralateral lobe on the left side, and no lymphadenopathy was appreciated. So what we have here is a 2+ centimeter nodule. She undergoes biopsy. This confirms the presence of PTC, as you might have suspected from the imaging. she's nervous, and she says that she wants her whole thyroid out. She wants a total thyroidectomy. She's worried. Just get it out. I don't want it in my body anymore. And so, Lindsay, maybe I'll start with you. How do you talk to this patient about extensive surgery? You're her initial touch point. And so she's coming to you as now her thyroid endocrinologist provider. And what do you tell her about the need for surgery with a nodule of this size? Does the fact that she's got likely Hashimoto's and she's not on levothyroxine now, but will she need to be? And does that make a difference? And then we'll go on to talk about some contralateral nodularity in just a moment.
Sure. So, I think obviously shared decision-making is always important, but it's really important that the patient is educated on sort of risk benefits of total versus lobe and understanding those options and weighing those risk benefits. So just baseline nervousness is not enough for me to just say, okay, do what you want. I mean, ultimately, I will support that decision, but I think it's really important to make sure that the patient's really clear about why she's making that decision and understanding that, where her fear is coming from and making sure that, of course, her fear is going to be valid, however she feels, but that we understand that and can have a discussion about that. So looking at the images, there's no extrathyroidal extension there. There's
so let's just presume let's presume this is intrathyroidal. There was no extrathyroidal extension.
Okay, so assuming it's intrathyroidal,
yes.
The two reasons why you would favor a lobe, one is because of lower surgical risk, and two is to avoid the need for levothyroxine. And you're right, she'll probably ultimately need levothyroxine, especially during pregnancy if she already has a TSH. Upper limit of normal, that 4, everyone's ass is a little bit different, but she's either slightly hypothyroid already or she's at the upper limit of normal. So she'll likely 4.9. Ours is 3.6 upper limit of normal. So it depends on 5. Okay. So, she probably will ultimately with TPO antibodies and already having a high normal TSH at 29 will probably need some thyroid hormone at some point. And so you could take that into consideration for the decision-making, but it doesn't change the surgical risk. So as long as she understands that a total thyroidectomy, is going to be higher risk in terms of hypoparathyroidism and recurrent laryngeal nerve damage as compared to a lobe, I think a total would be reasonable, but she has to sort of be able to accept that risk for surgical intervention.
Can I ask Dr. Noel, I get this a lot where it's like, they've got Hashimoto's, we should just automatically do a total thyroidectomy. But sometimes I hear you guys talk about the Hashimoto's glands being sticky and maybe a higher rate of hypoparathyroidism and nerve. And does that sort of factor into how you're thinking about it? I mean, it's easy for me, I don't have to do the surgery, but Hashimoto's versus not, any difference in sort of complication rates and how you think about it?
Yes, there certainly can be, and there's a lot of data out there that's a little bit mixed on what complications may or may not be elevated in Hashimoto's glands. Certainly, I think we've all had those cases where we know patients have wildly positive TPO antibodies, and it can be a really miserable surgery. So that certainly is a consideration when counseling patients on the risk of doing both sides, that there is the chance that could potentially lead to, additional complications. And especially when thinking about the status of parathyroid glands at the end of surgery, when we're not so worried about that with just a lobectomy.
Laura, can you weigh in on the fact that she's got contralateral nodularity? It's a small nodule, but how does that factor into your decision-making, your recommendations in terms of thinking about surveillance, thinking about her concern for, having to monitor that nodule? How does that weigh in your decision-making?
So, the reality is that the American College of Radiology and the American Thyroid Association only recommend biopsying thyroids for nodule like the one on the contralateral side when it's 1.5 centimeters and and larger. And this one is 7 millimeters, if I remember correctly. It's small. We don't know whether it's malignant or not. Likely it is, because of the way that it looked. It was hypoechoic, and the patient, the reason why I would, there we go. No, it's actually not hypoechoic, it's hyperechoic. So I'm not entirely sure what makes it Thyroid's 4, but
That's how it's treated.
yeah, it's being reported Thyroid. Maybe it's
Still
vascular.
7 millimeters.
Yeah, so maybe it's a vascular nodule, and that's what makes her Thyroid's 4. I do tell the patients that this is a small nodule that could potentially represent thyroid cancer, and that she may, this may grow in the future, albeit very slowly, and we have the opportunity to watch this. But as Dr. Bishop was saying, the fact that she has already borderline thyroid hormone levels and Hashimoto's disease, that puts her at an increased risk of needing levothyroxine replacement on a lobectomy surgery, doesn't give her an advantage of removing half of the thyroid if she's going to have to monitor a contralateral microscopic nodule that is going to go through the she's doing IVF. She's probably going to receive hormones. We know that hormones of pregnancy and future pregnancies will make this nodule probably grow. So, it's she's worried not only about one nodule, but about 2 nodules. And so the fact that it's small doesn't necessarily mean that we are going to say we're not going to biopsy, or we're going to offer you surveillance. In a way, you're putting together the social factors, her worry, the fact that the contralateral big one is already a papillary thyroid cancer, and the fact that she's probably going to need levothyroxine replacement. So, in that sense, you counsel her in a way that she understands that probably this nodule may grow in the future because of all these hormones and future pregnancies. I'm probably going to have to keep a close eye on her. And if she wants peace of mind, probably total thyroidectomy may eventually be easier to undergo than lobectomy initially, and then a completion thyroidectomy afterwards. I wanted to also touch base on the Hashimoto's situation. We typically see enlarged lymph nodes in the central compartment and in the lateral compartment in patients with Hashimoto's disease. And this ultrasound didn't really show any Hashimoto's-like lymph nodes. And so, in that sense, I don't know how wild her Hashimoto's is to, as Mike was saying, make the surgery a little sticky, difficult, and all of that. So in her, it's a good prognosis that at least we don't see enlarged lymph nodes in the central compartment related to Hashimoto's or not, or to thyroid cancer.
So we're really talking about sort of a patient-centered decision. It may be different depending on the patient and the patient's needs, all the individual factors we've talked about. Knife, I wonder if you could comment just for a moment on this patient has elevated thyroglobulin antibodies. Does that weigh into your decision-making in terms of surveillance, whether you consider a hemi versus a total, and how so?
Yeah, so first of all, I agree with what everybody was saying. I think this is a patient who's a nurse, right? She's in healthcare, and you need to think about all these factors that have been mentioned, right? Surgery may be more difficult. Central hypopara may be more of a problem. It may not be. I mean, in Dr. Noel's hands, it's probably all easy. But she probably will be hypothyroid, whether you do a hemi or total. And the new guidelines that are going to come out, the hints that have been coming out is that they're going to suggest less follow-up rather than more follow-up if you did, you know, a total thyroidectomy and you don't have disease for a shorter time. So these are all things that need to factor. Whereas if you leave a nodule there, it's probably a lifetime follow-up. Not that, but it's important for her to understand that outcomes don't change necessarily with subsonometer disease, even if we took worst case scenario and it's a PTC. So in terms of the TG antibody, so usually thyroglobulin disappears 1 month after surgery if you do a total thyroidectomy with or without radioactive iodine, whereas TG antibodies can take a median of 3 to 5 years to disappear. So first off, you do a hemithyroidectomy, the guidelines recommend against following thyroglobulin. However, I still do in general, just because I think it depends, right? If you can control your own and your patient's anxiety about what the thyroglobulin means, then I think it's fair to follow it. And you're just looking for big rises, right? Whereas in general, so with TG antibodies, if you're still going to have them present in the face of a total thyroidectomy, you just tell the patient that you should see them stable or coming down. And if they go up, that's the problem. Pregnancy can change that as well with the immune system changes. So it depends, you know, when she's going to think about trying to get pregnant, but it doesn't necessarily change whether I do a hemi versus a total.
Okay, great. Well, thank you for all of that commentary. So she underwent a total thyroidectomy, which she had elected for. She had a good surgical outcome, and you can see her pathology here. She had a PTC as expected on the right side, very reassuring features, and then a small PTC on the left side, whether or not it was that nodule, not clear. She did have 6 nodes that were included with her specimen. She did not have a formal neck dissection, but none of those were positive. So we'll move on to case number 2, unless, Mike, are there any questions in the chat that you want to address at this moment?
No, none yet, but feel free to add some in as we go through.
All right.
Did she get pregnant? Did you let her get pregnant?
Oh, I don't think she's pregnant yet. She wants to get pregnant. She's trying. Yes. So this is a case of a 47-year-old woman. So she was undergoing evaluation for what turned out to be an Ewing sarcoma in her buttock. And this was found actually on physical examination. It was small and early stage. So during her workup, she was also found incidentally to have an FDG-avid thyroid nodule. She has no personal history of radiation. You can see her the remainder of her history here. She's also a nurse. She works in oncology, in fact. And so this is the ultrasound here of the FDG avid nodule. It measures 2.6 centimeters, graded at TI-RADS 5. You can see it's hypoechoic and irregular borders here. She has no lymphadenopathy on imaging, on her ultrasound or on CT. And then I'm just going to play the cine clip of her ultrasound because you see she's got also some very large, she's got a large thyroid nodule on the left, a goiter. It appears very benign. Of course, was not FDG avid, but she does have left-sided contralateral disease. So we've talked a lot about unilateral versus bilateral surgery, extent of surgery. So we won't repeat that conversation. She underwent elected for a right hemithyroidectomy, and her pathology showed a 2.5 centimeter tall cell variant PTC. There was microscopic extrathyroidal extension, no vascular invasion. She did have one node that was microscopically positive without extra, that should say nodal extension. So she's currently planned for a completion thyroidectomy and with radioactive iodine treatment. And I want to ask, maybe Lindsay, you can start out here. What are some of the factors that you consider when recommending completion and RAI? Maybe you can help us sort of walk through the patient and tumor factors that you think through as you're making a recommendation for this.
Certainly. So a couple of things that jump out about her surgical pathology, which is, of course, how we base these decisions, was the tall cell histology. So we know that carries a higher recurrence risk and can be more aggressive. There was some extrathyroidal extension. I think, did you say microscopic?
Minimal, microscopic.
And you know, that has been pretty debated in terms of its impact. I think we're starting to have some data that maybe posterior extrathyroidal extension might be higher risk than anterior. So I'm not sure if you know if it was posterior or anterior. But again, sort of gathering some of these concerns, tall cell, a little extrathyroidal extension. If you don't mind going back to the path again, just so I think there was, okay, one lymph node, it's a 4 millimeter, but again, kind of gathering these little concerning features that, it doesn't, other than the tall cell, we're not seeing really aggressive high risk disease, but certainly it's going to be sort of a higher intermediate type risk for recurrence. And so, that would indicate that radioactive iodine would be beneficial. And in order to facilitate that, you would need to do a completion thyroidectomy.
So what if this were tall cell features and not tall cell variant? How do you
Yeah.
tackle the patient then?
Great question. So, I mean, I think that tends to be different, and we don't see that with the same degree of aggressiveness, although I'm not sure how much data we really have to, a lot of these things are based on sort of small retrospective bits of data, and we do our best to pull, our clinical recommendations from there. But tall cell variant, really is a higher risk feature where we see tall cell features. We don't put that in the same bucket typically.
Julia, perhaps I can ask you, if your patient comes back with tall cell features, and so for our audience members, we consider tall cell variant to have at least 30% of the field have tall cell features present, but this is less than that, so it's not tall cell variant. It's a sort of an unclear, a little bit of a gray area. Julia, how do you think through this problem with your patient? How do you connect with your endocrinologist? What is your sort of pathway for, as a surgeon, working through this kind of decision?
Yeah, I think this is a very nuanced discussion that really benefits from a multidisciplinary tumor board at times, especially because you have the benefit of your pathologist to, show you the slides and tell you exactly what they're seeing. Tall cell features can indicate a varying percentage of tall cell in the whole histologic specimen. And, there's really no data that tells us what is the cutoff for being concerned about the potential behavior of a tall cell featured nodule. Is it 5% of tall cell features? Is it 15? We don't really know. So again, this is just a really, really nuanced discussion, and I think ultimately comes down to, some combination of the patient's level of concern as well as our level of concern about the behavior of the nodule. As Dr. Bischoff said, it's very reassuring that we see no vascular invasion. The one metastatic node was a microscopic deposit. So there are other features that are sort of more in her favor, but I think that is a discussion that certainly benefits from multidisciplinary input.
So we've decided that this patient is going to get radioactive iodine.
Well,
and so
Whoa. I haven't talked yet.
Laura's been very quiet.
Laura
Yeah.
wants to add her 2 cents.
My
I
two
want to play
cents
devil's
are
advocate.
my 2 cents are actually the exact opposite approach to Dr. Bishop's and Noel's approach. So let me advocate for the complete opposite factor. Put the pathology report right there because I need it in front of me to justify my recommendation. So I just want to make the counterpoint and the way that I think through this case. So we know that papillary thyroid cancer classical type is 60% BRAF V600E mutated. This comes from data from the TCGA. And we also know that 80% of tall cell variant papillary thyroid cancers have a BRAF V600E mutation, around 80% of all tall cell variants. So the reality is that BRAF mutant papillary thyroid cancers downregulate the sodium iodine symporter and express less on the membrane the protein that incorporates radioactive iodine. So if we are thinking that we are going to treat a BRAF mutant papillary thyroid cancer, tall cell variant with radioactive iodine with the purpose of decreasing the recurrence rate, well, let me tell you that these are the very tumors that do not respond to radioactive iodine. And if anything, these are the very tumors that respond to surgical resection. So I do not, having said that, 20% of BRAF mutated papillary thyroid cancer do maintain the expression of iodine metabolism genes and preserve the sodium iodines imported in the membrane. So if this were a New Yorker where we, take risks, we sit on stuff, and we can follow people over time, I honestly do not see the benefit of administering radioactive iodine to this patient. Because radioactive iodine is not going to change her prognosis. I am not entirely sure that she falls on the intermediate to high risk. Yeah, there are a couple of small factors, the tall cell variant, the microscopic extracellular extension, 5% risk of recurrence, 1 out of 3 microscopic lymph nodes, really, that doesn't really increase the risk of thyroid cancer coming back. So if I were to estimate the risk of recurrence in this patient, I would say 5% in her entire life, 5 to 8% in her entire life. If you tell me where is the data supporting that radioactive iodine is going to lower her risk of recurrence from 5 to 8% to less than that, there is no data to support that. No data to support decreased risk of recurrence, no data to support improved survival. So honestly, I really have a deep conversation with the patient, and I tell them, if you're going to go for a completion thyroidectomy, it's because you have a massive goiter on the left side with a benign nodule, and you just simply want to take it out and get it over with. But that was a conversation that I should have had when her PET scan came back and you had the ultrasound before in the initial surgery. If she elected to have a hemithyroidectomy, and this is the pathology report, with this precise pathology, I don't know that I would recommend the completion thyroidectomy and addition of radioactive iodine.
And does the FDG avidity influence your decision?
Totally. Like it even supports it even more. The FDG avidity goes against me administering radioactive iodine. The more FDG avid a tumor is, the less likely it is to concentrate radioactive iodine. So, there are
a couple of things, Laura. So first of all, I totally agree that watching and waiting is not going to harm the patient anyway. And of course, we know that BRAF is less iodine avid than, these RAS follicular tumors. But of course, as you said, a lot of these papillary thyroid cancers, including classic type, are BRAF V600E. So I guess the question for you then is, are we recommending that anyone who has a BRAF V600E mutation not get radioactive iodine? Because I think, I think we're, I think we need to question who we're giving iodine to. And we really just started doing that when, Mike Tuttle said, maybe we don't give these to low risk patients, but, oncocytic, it's the same debate where these are rarely iodine avid, but from a clinical perspective, the few that are, and you don't know that until you treat them, it's a tough clinical debate. While the science makes sense that it down regulates the sodium iodine symporters, they're going to be less iodine avid. I think the concern is, can we use that to sort of make a blanket statement that these are not going to be iodine avid and we should therefore not give them radioactive iodine? I think that's the tough part.
I think that what needs to happen is that we need to better understand who among these BRAF mutated patients would respond to, or would benefit from radioactive iodine therapy. As we know, 20% of these BRAF mutated patients have the potential to respond to this, but we still have not identified who these are. Is it dependent on microRNAs? Is it dependent on additional concomitant genetic mutations? I wouldn't make a blanket statement, but at the same time, I would be very, very cautious to start treating with radioactive iodine to every BRAF V600E because it's a higher risk of recurrence, because those are the very tumors that do not respond to it. So let's be cautious and let's figure out who will benefit from radioactive iodine and who will not.
So
So
clearly
two
a
points I
very,
just want to add. One is, so if the patient came to MD Anderson or Memorial Sloan Kettering, it sounds like they'd have a copy paste discussion. Okay. So let me just, for many reasons, that we would not necessarily advocate, or at least discuss with the patient, that a completion thyroidectomy radioactive iodine is probably not going to change your risk recurrence. Let's take out tall cell variant from the equation for a second, because many pathologists feel like how tall is tall, so they don't even call out tall cell anymore. Okay. So even if we had a 2.4 centimeter PTC, we did know that it was a tall cell variant and it had the sub-centimeter node in there, then, many of us, well, I'm not a surgeon, but many of us are doing hemithyroidectomies with that node dissection, right? And because they're young, you're going to find these small PTCs in their lymph nodes, and it's not going to change their prognosis. So I would not advocate for radioactive iodine unless there's something suspicious in that neck. They'd come there and get an ultrasound. Now, adding the tall cell with the BRAF picture, it depends on who you go to, right? Like Lindsay and Laura were saying, people are doing now BRAF IHCs and saying, hey, it's positive, let's not treat with radioactive iodine. And I don't know what the right answer is. And same thing with if they see oncocytic. So I do think that's an argument to be had, or a discussion to be had.
so this is clearly a very challenging and nuanced decision that you all engage with. I want to switch gears a little bit, just for our audience. As surgeons, when we do send patients for radioactive iodine, we say, oh, the endocrinologist will tell you all about it. So I want to hear from you. What is it that you tell your patients when you're counseling them? Say this patient is going to receive radioactive iodine. Walk us through, perhaps, Lindsay, you can walk us through what is the conversation you have with your patient about the practical items that they need to know. What are the risks? What is it going to look like? What are they doing? Are they taking a pill? What is happening? As surgeons, this is all sort of it happens outside of our view. So I want to hear just very quickly, what is the conversation that you have with your patients and when you counsel them that this is what you're recommending?
So I usually tell them it's a huge pain in the butt. I'm in Nashville and there's not a lot around. And so we have patients that travel 3 or more hours. And so, typically I use recombinant human TSH. And so that requires 2 injections, 24 hours apart, 24 hours for the radioactive iodine. And we do it all on our main campus at Vanderbilt. And so hotels in Nashville are expensive to stay. And it's not a great, it's a complicated process. And then of course, we do use a low iodine diet for a week. I know that is a bit debated. I don't do any urinary iodines. If they've had a contrasted CT, I usually just wait 3 months, but I don't monitor urinary iodines. And then they have to go on this sort of semi-isolation because the radioactive iodine can transfer to others in bodily fluids. We continue to work on our communication with our nuclear medicine department. And so they end up giving them a very specific time frame in terms of how long that isolation is. I typically say 5 days just to kind of cover my bases. You hate to say 3 and then they find out they need an extra day off of work or away from their family or whatever. And, I tell them it's an oral therapy. They can feel nauseous at the time. They can rarely have sort of mucosal sores. We have viscous lidocaine we can give them. We can give them Zofran if they need it. Typically they don't. Certainly salidinitis can occur. And so we tell them to stay hydrated and massage the area if it gets swollen. I think the data on sour candies is not so great, so we don't recommend that. And then they come back again. So I'm always like, that's a fourth time. Come for 2 injections, you come for the iodine therapy, and then you come for your post-therapy scan. We don't do pre-therapy scans routinely because it's not going to change.
Explain the significance of that to our surgical audience.
Yeah, and there's definitely differences of opinion there. You know, if again, you know, there's really 3 reasons to give radioactive iodine. There's remnant ablation dose for low risk, which is not really what we're talking about and not something that we do at our institution. Then there's reducing the risk for recurrence, which is what we're talking about here, which is the majority of the reasons we give radioactive iodine. And then there's to treat known metastatic disease. And so that treating known metastatic disease is a little different. That's different, and this sort of scan setup could be different. But in terms of reducing recurrence risk, we're basing that on a number of factors. Certainly their surgical pathology is going to be the main driving force. Also, their post-operative thyroid globulin, you know, what things look like post-operatively. And so those are the reasons we're giving the radioactive iodine. We're giving it to destroy microscopic disease that I wouldn't be able to see on a diagnostic whole body scan. And so I'm not looking for structural disease to justify the therapy, and you're going to have a much more sensitive scan after radioactive iodine. A diagnostic whole body scan a post-therapy whole body scan is going to be more sensitive than the diagnostic. So we don't do it because it's an extra step that wouldn't change our management.
How do you decide the dose? Who decides the dose to administer? And
Is this me or someone else?
We make it up.
Yeah, I was going to say, I can tell you, but maybe
Seems
someone
very
else has a
random
better answer than
sometimes.
mine.
Numbers that you know are very random.
We don't do dosimetry for the most part unless someone has really large volume. Yes, and I see Brennan Sachs' the diagnostic scans, concuss and stunning. But unless someone has really like miliary lung mets, that I'm concerned from a safety perspective, that I say, oh, you've got lung mets, I want to treat you with 200 millicuries, and that's going to cause a radiation pneumonitis. That would be, you know, bad. So that we would do dosimetry, but otherwise it's empiric dosing, which is basically an educated guess. And so if it's a higher risk patient, you know, that's really concerning disease, I would give 150. And if it's sort of an intermediate risk patient that I still think needs radioactive iodine, I'd give 100. That's about as fancy as it gets.
Thank you, Laura. Can you explain dosimetry to us simple surgeons?
Oh, yeah, sure. Dosimetry can be done with a bunch of different radioiodine isotopes. We at Memorial have 3 different ones: iodine 123, iodine 124, and iodine 131. These are different isotopes with different pharmacodynamics that essentially have slightly different properties from each other. The newest one of them all is iodine 124. It's very expensive. It's experimental. It's not widely available. And to my understanding, you need a special cyclotron and stuff like that to make real stuff. But you can ask these people who worked in the military a while ago, and they can tell you. So the iodine 123 uses essentially a small dose of radioactive iodine for which you will not need isolation, and administers a tracer dose of radioactive iodine to the patient, and you can make a picture of that. You can make a picture of the neck. Typically, you make the picture of the neck alone. You could potentially make a picture of other parts of the body with a whole body SPECT CT. You can do that either with iodine 123, with 124, or with 131. And what it gives you is an idea of which cells, either remnant normal thyroid tissue or metastatic thyroid cancer, would take up radioactive iodine. When you are actually treating a widely metastatic thyroid cancer patient with known lesions in the lungs, in the bones, elsewhere in the body, you can use multiple measurements of the iodine uptake in individual cells to understand the kinetics of the isotope and calculate how much radioactive iodine is retained in the thyroid cancer. We know that 2/3 of patients with metastatic thyroid cancer have radioiodine refractory disease, but if you actually do this dosimetry, you can visually see what lesions take up and how much iodine they retain over the course of a full week. This is done Monday, Tuesday, Wednesday, Thursday, Friday measurements, and we have a physicist that essentially makes the patient come, pee in a cup, have blood work, and you get a scan 3 days in a row. We're trying to simplify that to have a single scan so that it's not so cumbersome for the patient. But to give you an idea, it's a way of assessing the individual lesional uptake of radioactive iodine by either metastatic lesions in the neck or elsewhere in the body, and calculate the maximum tolerated activity that that lesion would require without damaging other organs in the body. That is, lungs in the case of the pneumonitis that Lindsay was mentioning, Dr. Bishop, sorry, that Dr. Bishop was mentioning, the bone marrow suppression in the case of a patient with some blood dyscrasias, or for the same matter, salivary gland uptake. So you could calculate absorbed dose in different organs, and that those are the basics of dosimetry, the ability to individually understand how metastatic lesions can uptake and retain radioactive iodine, and what's the dose that you would need to administer to prevent, to do two things: to concentrate the maximum dose of radioactive iodine in a lesion and to prevent damage to adjacent organs. That's the basics of dosimetry.
Very helpful explanation. Thank you. I think in the interest of time, I think we will move on to our next case, unless, Mike, there are any questions in the chat that you think.
There were a couple of good questions. This one will go to you, Noel. This is from Dr. Singer. Does the presence of a parathyroid gland, and then he puts in parentheses, or even two, because this would never happen to Mike, but theoretically, if one or two parathyroid glands came out on the other side of the country, when you did your initial hemothyroidectomy, you're planning a total thyroidectomy. So speak to a little bit of that intraoperative decision-making. Either you lose the signal or you have a parathyroid issue. How does that translate into your surgical decision-making?
Yeah, absolutely. And then, one is a different scenario than two. It's also a different scenario if you have some sort of confirmation intraoperatively, if you're using a device of some kind to confirm presence, confirm vascularity. But most people at this point probably don't have access to either or both of those things. I think you have to be very careful, and especially as we've talked about the benefits of completion and RAI versus not in this case, that, if you have two non-viable glands from the first side, or you have two excised glands from the first side, that's probably another point in the column of let's think twice before we go back. If you have one excised gland, then I think it depends on your level of confidence in the remaining.
Yeah, right. So it's kind of, there's lots of decisions that get made intraoperatively that we don't understand that you guys make, but it's important for us to know, right? Even when we say we want a lobectomy, I often say, but Dr. Shaha is going to make that final decision when he's in there, because if he sees something, we consent usually for lobe and total, right? Based on those intraoperative findings. So that's good. All right, let's do our last case. This one's an interesting case. And this is going to get at that issue of what we call detectable versus actionable. We can find stuff, but when do we do something about it? And often it's the endocrinologist finding stuff. We usually refer to Dr. Bukai as the most aggressive surgeon at Memorial. She doesn't really have to do the surgery. We just recommend it. It's not her neck. She's not the surgeon. It works out great. So here's your case. 89-year-old female. So Dr. Russell gets to do all the 20 and 30-year-olds, and then they let the old guy do, I guess I have more in common with an 89-year-old. So here's me and my 89-year-old friend, locally advanced papillary cancer. So this is a bad one, total thyroidectomy, right recurrent laryngeal nerve paralysis some 14 years ago. Gets a dose of radioactive iodine with some uptake in the neck. We don't really know whether that's thyroid bed or a thyroid cancer. About 8 months later, she gets more surgery for central neck and more lymph nodes they're seeing, and does find that about 7 years down the road has another neck dissection. Those are her past medical histories. The next slide. You see on here, she definitely has some persistent disease. Naifa, you want to talk about this? The antibodies there, and then that TGRIA thing. How do you sort of look at this table here?
So I think this is very helpful to have this table. So when patients often come for the first time and we're seeing them, we want to get their old data. So we'll either call the outside physician, or in this case, the patient brings it with them. It's great. And so what we're trying to tell the patient, I can't remember the date, I think it was 2012, right? So we don't have that, but we talk a little bit about what's residual versus recurrent disease. And so if they never had their thyroglobulin or their thyroglobulin antibody go to 0 prior to the next time that disease was found, especially if they didn't have regular ultrasounds, to tell them this is residual disease. Because the number one worry for these patients is, how many times are you going to go back in my neck? And, this disease keeps coming back. It's, deadly. And so if a nidus of disease is left behind, right, the likelihood is that it's going to continue to grow and come back. And so in this patient's case, now they've had their 2 surgeries or 3 surgeries, and their thyroglobulin antibodies are actually fairly stable. And their TSH, you can see that from 2019, 2020, the thyroglobulin goes up a little bit, but the TSH went up a little bit. So we always tell them, explain to them that we look at it in the context of the TSH. But then when you go the next year or 7 months later, the TG is up a little bit more, but the TSH is a little bit more suppressed. And so I explained to them that thyroglobulin antibodies don't do the same thing that thyroglobulin does with the TSH. It can be helpful if it's really rising and follow trends, or really lowering. So in this case, it doesn't help us at all. It doesn't tell us about the disease. Now, some people will measure a TGRAI, and what they're trying to do there is to see if they can tell how much thyroglobulin is and get at a level, instead of just looking at the antibodies. And in this case, it wasn't very helpful because the TGRAI is in the range of 13 to 16, which is about the same range. So it's helpful in the sense that from a biomarker standpoint, their levels are not moved in 3 years. And I don't know what you said about the imaging. Did I miss that?
Oh,
You
we
got
got
it.
it there. So Laura, if you had go back for me when we're good. So several recurrences in the neck over 3 or 4 or 5, 6, 7, 8 years. TG that's still persistent. Where's her disease, if you had to guess?
In the neck, but this is another example that radioactive iodine didn't work.
Didn't work as well as you wanted it to work. See, I'm
Right.
trying to be optimistic here. So
Okay.
but we're trying to keep our surgeons in business.
Yes.
All right. So Dr. Russell, what do we see on the scans?
So these were her scans, most recent scans from 2023. So you can see here, I've marked it. She's got a contrast allergy, so they're non-contrast scans. And you can see that she's got this lesion in the right base of neck. It's kind of lateral to the carotid. Maybe it's central, don't know. And there's a question about that I want to put to Dr. Noel, which is, does it matter where it is in the neck, whether it's central or lateral when it's this size? What are the factors that influence your thinking as a surgeon in terms of the difficulty and the issues that you want your endocrinologist to be aware of as well?
I mean, it certainly does matter. Central neck disease, the threshold to go back is, for most people, I would say higher, because scar tissue really impairs our ability to distinguish the structures that we're interested in preserving. I think in this patient's case, if I remember correctly, her nerve is out on this side. And so that is less of a consideration, but we don't know the status of her parathyroid glands. And while it may seem you know, like a straightforward thing to go dig this out of a central neck, that is a consideration. This looks like it's lateral to the carotid and actually sort of in a tricky place at the confluence of maybe the IJ and subclavian. So that in and of itself is not a friendly place. You're thinking about the veins. You could have a thoracic duct on that side, less commonly, but possible. So this is, despite being in the lateral neck, not a friendly place.
So when these come up, Dr. Noel, oftentimes when they're down low like this or high rectopharyngeal, oh, there you go. I'll come back to you and I'll say, is this an area that you would have expected to be missed with a prior surgery? Is this a common place? It sounds like from your description, that's an area you wouldn't want to go on surgery number 1, 2, or 3. So the likelihood that this has been there the entire time, speak to that just a little bit.
Yeah, I think in combination with the biomarkers and the imaging, it's likely that this is residual disease. It's been there the entire time. This is an area that is frequently missed during initial neck dissections. Exactly for that point, you can see it sitting behind the clavicle. It is at the venous confluence. It's not an area that you, you know, necessarily want to be, but is, as we know, necessary for thyroid cancer.
Gotcha. Lindsay, how do you frame this discussion of recurrence versus persistent? Right? This lady's had persistent disease, as Naifa said, the entire time. So do you leverage that to be reassuring or worrisome, or you have?
I do, you know, we all have a different way of sort of addressing things within the context of each patient. And this is an 89-year-old patient who is on Eliquis. She's got, there was several, she had Crohn's, I think it didn't sound like she was maybe breast cancer. Was that in remission? I don't know. So she's 89 with some medical history that is not otherwise favorable. And, you know, persistent disease we see grow over time, but the question is it ever going to be truly problematic to her? And then you have to weigh the risks and the benefits. She's already had 2 or 3 surgeries, and this is not in a favorable place. And so I think, you know, 89 is not always, you know, there's 89 and there's 89. They can look totally different in terms of, you know, how sort of spry we think that patient is and how they will do from a surgery. But the question is, when's it going to end? Because there's probably going to be something else that pops up, and, you know, we're not saving her life in this situation. And so unless there's really a need structurally that it's going to be, you know, invading, and we're going to have some sort of morbidity as a result of tumor growth, I would typically give reassurance that the you know, risk of intervention is higher than watching. And I would watch it, because at some point maybe that would change. Yeah. But that would be sort of where I would favor. And it's grown over 2 years, certainly, and I would expect it to continue to grow. But that doesn't mean it's going to necessarily impact her life at her sort of age and health status.
That's great. I can see in the webinar, some people are raising your hands. Everybody's muted. We can't do that. So just put a question in the chat, and Marika will get to this. Laura, very often at our Thursday morning head and neck conferences, we have a case like this. And the question always comes up, what's the goal of your surgery? Or Lindsay already mentioned, not going to cure her by taking this out. So if you were thinking about a surgery for this, what would be the goal of your surgery? What would you ask the surgeon to be doing, Laura?
So I would ask my surgeon, can you safely take out, in the context of 89 years old, can she tolerate the anesthesia with her atrial fibrillation, and get in and out, take this out to prevent this lymph node from, eroding into the whatever that is, the carotid artery or the IJ. I honestly think like Lindsay in this one. I don't know that it needs to be resected. The surgeon is not going to care, as Julia said, about the recurrent laryngeal nerve, which is out on that side. But, the parathyroids, if they are out on the other side, we might have a concern. There has to be a real reason for the surgeon to decide to remove this. I don't know that you would prevent it from growing into blood vessels that might cause a clot or some complication in the future. Having said that, this is slow growing, and she's more likely to die of an arrhythmia or a heart attack than from tumor growth itself.
Dr. Noel, help me. There's a lot of comments in the chats, like supporting the surgeons. The Brendan Dutchstack said this may not have been missed; it may have been avoided. We didn't want to go down there, right? And it's near the inferior thyroid artery, that sort of stuff. If we twisted your arm and sent you in to do there, what would you tell this lady that I understand one of your goals of surgery is not to hurt her, right? Get her alive and not
Right.
cause such damage. What's the real, for the endocrinologist here? What are your real concerns with operating in this area here?
Yeah, and as Brendan said, this is an area that is often avoided the first time around or even the second or third time around because of the risk. This is sitting at the confluence of two large venous structures. And it is also in an area where you could have a thoracic duct or tributaries thereof. So especially in an 89-year-old, and looking at this particular coronal CT scan, it doesn't look like there's a super clear boundary between the node and the blood vessels. And so you have to tell the patient, a possibility in going under this surgery is that we get into really terrible bleeding and it's behind your clavicle and we can't see it that well. And maybe it retracts into your chest and suddenly that means a bigger surgery than you signed up for. Or you have a chyle leak afterward that has to be managed.
Yeah, this is a real thing. NIFA, often Murray Brennan, who's one of our senior surgeons here forever, Murray would say in a case like this, they have to earn an operation. It's not just good enough to say we have disease. What would this patient in your hands do to have to earn an operation given all of that background that you talked about here?
I think for
Yeah.
an 89-year-old, oh, sorry, go ahead, Naifa.
Oh, sorry.
Yeah, go ahead, NIFA. You go first. NIFA, tell me.
Oh,
Earning that operation.
Yeah, so I agree with what's been said previously, and I agree with your surgeon that you have to earn an operation. So really having the CT scan from 2 years ago, I think is very helpful. Over a 2-year period, this has barely grown. It's, I don't know, what is that, 2 centimeters or something? I don't know how big that is. And surgery has risks, and this is a patient who is 89 who has Crohn's and is on Eliquis, right? So there's a lot of risk here. And so to me, you're making less and less of an argument for surgery. Now we can do a short-term follow-up, and if it progresses, we can talk about that. But I agree with you. I would definitely, this was probably avoided, missed. It's similar size over a 2-year period. She has to earn an operation. I like those words.
Dr. Russell, as we're winding down, any option for some sort of heated up tip of a needle sort of thing? How do you sort of think about this in terms of a thermal ablation or something like that? An option for something like this?
Yeah, that's a great question. I think one of the challenges will be adequate exposure, as this is deep to the clavicle, and so getting getting an ultrasound view of this nodule is going to be challenging. So that's the first issue. You're also you question perhaps the utility if it's sitting there and not doing anything. Are we potentially causing harm by treating her? So I wanted to pose that to the panel as well, if anybody would consider offering, now that I've mentioned all those hazards. This is something that we want to think about in terms of offering this patient an intermediary type of treatment that isn't observation but isn't surgery.
Yeah, I find many times the very ones that you don't want to operate on are the ones that we shouldn't probably be doing ablation on for all the same reasons, right? Those all kind of go together. When we look at what drives us to do something or earn an operation, I use I do checklists for everything, right? So it's 5 things. What's the size of the lesion? What's the location? What's the rate of change? How rapidly is it growing? Is it going to cause symptoms? And then the last was patient preference. So size, location, rate of change, and patient preference. So we are right up against the hour at 1 minute. Marika, you want to finish off? Oh, let me say thank you to Dr. Russell. She put the slides together for us and made our job really, really easy. So great job on that. I'll let you finish up in the last minute here, Dr. Russell.
Well, I'll just finish up with the conclusion that this patient did undergo surgery. It fortunately went quite well. So she did well. But again, I want to thank our panelists for your expertise, for lending your time, especially to Naifa, who is currently on vacation in Greece. It's 3 a.m. where she is. So thank you for joining us. Really, we appreciate your presence, all of you, for your great, insightful comments. And I want to say goodnight to our audience. Thank you for being here, and sorry that we were unable to get to all of your questions, but you know where to find us. All right, take care.
Thank you.